right. So welcome everyone to the Educate series panel discussion on HIV, vaccines, and comorbidities. My name is Francesco McAllister Caruso. I use he, him, or they, them pronouns interchangeably. I'm the Director of Francophone Affairs here at Capital Pride, and I'm going to be your host and panel moderator this evening. Capital Pride and its team members are located on the unceded and unsurrendered territories of the Algonquin and Anishinaabe, who have lived and cared for these lands for millennia. As uninvited settlers, we commit ourselves to decolonizing the spaces and the events that Capital Pride organizes, and we strive for reconciliation wherever we find ourselves. As we settle in tonight and get ready to hear from our wonderful panelists, I invite our viewers to also consider the ways in which we can all recommit ourselves to the work of reconciliation every day, both as individuals and communities. The notion of solidarity lies at the heart of 2S LGBTQ activism. So, as we celebrate this Pride season together, let's also take the time to reflect on the ways in which we can stand in solidarity with other people's struggles for equity, justice, and liberation. Now, before we get started, let's get through some quick housekeeping. As someone who works in the field of health research promotion myself, I am very excited to hear from our guests tonight as we explore the impacts that the COVID-19 pandemic has had on people living with HIV/AIDS. We've prepared some questions for our panelists in advance of this evening, but we also want to hear from you. So if at any point during this event you have a question for our guests, please send it in the chat and we will get to it towards the end of the panel. Now, without further ado, let's get started. We've come a long way in the fight against HIV/AIDS since the first outbreaks in the 1980s. Between the development of antiretroviral therapy, ARV, to reduce one's viral load to undetectable and untransmittable, increased access to HIV prevention drugs like pre- and post-exposure prophylaxis, PrEP and PEP, and at-home HIV self-testing being approved in Canada last year, many technologies have helped to improve HIV treatment and prevention across the board. However, many barriers still remain. Widespread misconceptions about U=U persists, even among the populations that would benefit most from its knowledge, like gay, bi, queer, and other men who have sex with men. Public funding for PrEP varies from province to province, which can be confusing to navigate when trying to get coverage for the drug. Furthermore, Canada continues to be a world leader in criminalizing people who live with HIV, a practice which disproportionately targets queer men, people who use drugs, sex workers, as well as Indigenous, Black, and other people of color. All of these issues have only been exacerbated by the ongoing COVID-19 pandemic, which has stretched our healthcare systems to their limit. In light of this, and the ongoing vaccination efforts to help stop the spread of the disease, today's panel discussion will focus on what impacts COVID-19 has had on people living with HIV, how vaccination efforts are shaping up for people living with HIV, what we can learn from past experiences, and how we can center HIV-positive people in our recovery efforts. All right, so joining us tonight are 4 panelists who are each involved in different sectors and aspects of HIV prevention, treatment, and care. Starting off with Dacia Hibbert, who uses she, her pronouns. Dacia was appointed to the role of General Manager for ViiV Healthcare Canada in November 2019. With over 20 years of pharmaceutical experience and 16 years in the HIV therapeutic area, Dacia brings a wide range of skills and expertise to her role. As one of the few women CEOs from diverse backgrounds in the pharmaceutical field, Dacia intends to make her mark by promoting a renewed role and perception of the pharmaceutical industry through easing access to treatment for vulnerable communities and further involving patients in the process of medicinal development. Dacia has a long-standing commitment to fighting against HIV, easing treatment accessibility, and promoting diversity in numerous fields. She initiated the creation of a new online photo gallery called HIV in View with the famous Shutterstock studio in the spirit of reducing HIV-related stigma. And during her time in office, she has already taken the lead in bringing injectable PrEP replacement medicine to market here in Canada and the US. As she says, our mission at ViiV Healthcare is to leave no person living with HIV behind. It's a pleasure to have you, Dacia. And now, next up, we also have Amir K. Bachari, who uses he, him pronouns. Amir is a medical student at the Royal College of Surgeons in Ireland, RCSI, and he identifies as a queer Persian cis guy. Prior to pursuing a medical degree, he worked as the National Project Coordinator at the Community-Based Research Centre, CBRC, for a pan-Canadian HIV prevention initiative and as an HIV prevention counselor at a sexual health clinic and pharmacy. He is currently conducting research on the impact of COVID-19 on PrEP uptake and on the rates of STBBIs in Toronto. His other research interests include the development of an inclusive medical curriculum and the importance of physician advocacy in addressing social determinants of health of their patients. Amir, I'm looking forward to hearing from you. Next, we have Safia Jama, who uses she, her pronouns. Born and raised on unceded and unsurrendered Algonquin territory here in Ottawa, Safia is a community-based mental health and harm reduction professional. She has over 6 years of experience working in various community settings with specialties in helping to create equity-based spaces, addressing and advocating against systemic barriers, and empowering communities to create sustainable change. Operating from an intersectional harm reductionist, trauma-informed, anti-oppressive, and anti-racist lens, her expertise is rooted within centering and amplifying pre-existing knowledge and the voices of her community. She currently operates as the HIV prevention strategy worker at Somerset West Community Health Centre. Safia is also a Master's of Social Work student at the University of Toronto and is interested in expanding her studies by focusing on the intersections of race, gender, and sexuality as it pertains to public health outcomes within African, Caribbean, and Black communities. Her goal is to continually create safer and empowering spaces that hold the heart of their community at its intersections. Safia, thank you for being here today. And last but not least, we'll be hearing from Chris Dranos, who uses he, him pronouns. Chris is a cisgender gay male who lives, works, and plays in Toronto. He's a registered nurse, currently enrolled in the Master of Nurse Practitioner program at Athabasca University. He's the TestNow research manager at the Community-Based Research Center, CBRC, that we mentioned earlier, and an in-person nurse at Casey House. His professional focus as a nurse is on the health of 2S LGBTQIA+ people, people living with HIV, and people who use substances or drugs. Good to see you, Chris. All right, so now with all the introductions out of the way, we can get into the meat of it and jump to our questions. So let's start off with maybe something a bit more broad to set the stage. I'm going to ask the question first to Amir, but also I would love to hear from other folks. How has the pandemic of COVID-19 impacted people living with HIV/AIDS?
Yeah, thank you, Francesco, for this and for everybody being here. Well, generally put, there's absolutely no question that those living with HIV have been impacted. But I do want to break it down to a little bit more specifics, even though we want to stay broad, and we'll go down into it. But there's two parts to this. The first one that I kind of look at is the virus itself. So the virus specifically has not really been shown to cause an increased vulnerability to COVID-19. And in fact, viral load and CD4 count have not been linked to negative COVID-19 outcomes through multiple studies. But the nuance is that in people living with HIV, there are far more comorbidities than those who are not living with HIV. And this is what puts them, at a disadvantage at the same stage or at the same, state that they would be in. So those comorbidities specifically related to COVID would be, hypertension and diabetes, which we might have heard of a lot through media or through other health professionals. And this is as a result of, inflammaging, which is a newer concept that we always talked about. And that is that HIV, even though we can achieve a suppressed viral load, the inflammation in the body kind of lingers and stays. And this is what causes an accelerated aging in somebody living with HIV. So, and then this is the more, medical side of it. And then the other side of it is the decreased contact with the healthcare system for a condition that is chronic and, requires daily medications to be taken. And oftentimes the support and that sustained relationship with the healthcare system helps keeps folks in care and, staying on top of their medication, getting their testing done. And the pandemic has definitely been a barrier, mostly needing to do virtual appointments unless necessary, for both the safety of the patient and also the healthcare provider. And then on top of that, we have the mental health piece and social isolation piece that, definitely played a role. And I'm sure there's others on the panel who are more qualified to speak to those. And how important these pieces are in HIV care. And I'm sure has had an impact on maintaining suppressed viral load and, staying healthy throughout the pandemic, gyms being closed, not having a lot of access to the same healthcare services that would have been there otherwise. So I'd say in all, it's had quite the substantial impact. And I think that bit of it is yet for us to fully see. We're still in the pandemic, so we have some time. There's still a lot of studies that need to be done. And once I think the pressure gets taken off of us, we might start to see those consequences. And I think one interesting thing that I've seen, and I've been looking into some of the studies, is this interesting thing around PrEP and taking PrEP, taking PAP, and HIV medication treatments. It seems that, and through some of the study that I'm doing, it seems that there might have been a decreased adherence to these medications through the pandemic. Evidently, some people thinking that they may not be as sexually engaged, so not taking their PrEP as their, as the regimen requires it. But obviously, they tend to still be engaged, and social isolation is not something that we can kind of sustain for a long time. So I think in general, that's kind of what I think sums up a little bit of those impacts.
It's very interesting to see to hear the medical side of it, and of course, like you said, the impacts aren't fully known yet. But I'm curious, Chris, what would you have noticed being a registered nurse? Is there anything on the ground with patients that comes up to you?
Yeah, I mean, I think that what Amir talked about in regards to the social isolation has been quite devastating for many people living with HIV who already were at disadvantaged in terms of generally just being able to have access to, unfortunately, the reality is many people rely on the social services and support services that are available. And so many of them closed down or had to switch to virtual engagements, and it really is not the same thing as an in-person social interaction. And also, I think it's also just important to understand too that people that are living with HIV, many of them, not everyone, but many of them do use substances like opioids or crystal meth. And the number of deaths related to substance use overdose during the pandemic has just skyrocketed here in Ontario. And it really shows that we have a poison drug supply and we have overdose prevention sites, or whatever they call them at this point. I mean, there's a new name like every week, it feels like, but really it's places where people can go and receive needles or pipes or other harm reduction supplies. And, there's death is not the only outcome too. People can get like wounds and like really bad infections. So it's been really devastating from that perspective as well too.
Yeah, touching on the social isolation part that you mentioned earlier at the start, and how that kind of amplifies everything, all the issues. I know that, I mean, for everyone that I knew, just going into social distancing and lockdowns with COVID has caused such a huge mental health impact. And when you live through different vulnerabilities, when you have different hurdles, that's just accentuated. And that actually makes me think of talking about how to counter social isolation and how to be better connected with each other and support each other. Safia, I'd be curious to know, how would you view kind of the role of community care in this pandemic in the context of HIV care? How would that work out for you?
That's an excellent question. I'm also just kind of reflecting on some of the panelists and what they've had to say. I think that generally speaking, the social isolation piece has had a really detrimental impact on the mental health of many people who have HIV and AIDS. And then on top of that, I think just to talk about what was really previously talked about, just a quick sec, I think that it also impacts, when we talk about adherence, like people, there's some real barriers in regards to even having access to technology for appointments, let alone even having internet, and even having access to those services. And I know that even, especially pertaining to people who use substances on the ground level, and just witnessing so many people pass away in the past couple of years, really looking at the detriment of what happens in a pandemic, and what happens when funding sources are cut, and what happens when people can go home and you have people in community that are a part of community that are more exposed and more criminalized due to various reasons and intersectional reasons. So that's one piece that I kind of want to reflect on. And then the other piece, in terms of community care, I think it's very important. I think that when we talk about community care, oftentimes we talk about self-care, and I think there's a huge commercialization of self-care, especially in these types of spaces within the COVID-19 pandemic. And when we talk about community care, it's more of a holistic approach. So self-care is community care, and community care is self-care, and there's a reciprocal relationship between the two that's actually really important and integral, especially for ACB communities, and being able to access care, let alone access services. And so a lot of that looks like, even before the pandemic, a lot of that is, it takes a community to raise a child. And so very integral to ACB communities is the idea of community care. And so what happens in a pandemic when people aren't actually able to engage within their communities, their self-care can then be at a detriment as well, because a lot of it's very intertwined within each other. So that's something that I've seen on the ground that's been really difficult for people to grapple, and definitely has impacted access in more ways than one.
Francesca, if I may just add 2 additional points, I guess, to your first question that weren't mentioned that I think is of importance as well. I think the other one is really deprioritizing other health related issues as well, because there was so much going on. And, you know, now it's those routine things that we need to get back to the doctors for, to check on outside of HIV. And the other one, I would say, to your point in terms of the technology and appointments, but it's how many times throughout the course of the day are we on a call and someone says you're on mute? So, you know, just think about it for folks who spend a fair amount of their time doing as we, you know, talking as we are now, but then to add that complexity to something that was simple as getting in the car or getting on public transportation. And so I think those are 2 huge parts that I don't know, I'm sure everyone on this call as well as myself are looking forward to having those, you know, just that level of in-person contact and appointments again very soon as well.
That's a fantastic point, Dacia. And actually that reminds me of something that I kind of realized throughout this pandemic. When we were starting, I was like, you know, trying to see the silver lining in this of like, oh, well, you know, more time at home if you're able to work from home, like less commutes. But really, you do lose that social connection aspect to it of not being able to see people in person as well. And all these kind of technologies that we've seen that were, you know, ostensibly created to help us connect more, like, you know, Zoom and the internet, has kind of led to a bit of a disconnect online, especially. And we've seen that, you know, with the COVID-19 pandemic. We've seen it with the vaccine rollout, where it is in the public health interest to get as many people vaccinated as possible. But to do that, you need to make sure that we have public trust first. And we've kind of been seeing over the past, you know, months, weeks, a bit somewhat of a breakdown in certain areas of like public trust in public health. And so I was wondering if you could talk about how we can deal with vaccine hesitancy, especially within more marginalized communities, and what are the ways that we can maybe strengthen public trust?
Yeah, such a great question. I'm excited about this one. So, you know, I think oftentimes what's quoted when we talk about public trust is the Tuskegee syphilis study. I had the absolute pleasure of going to undergraduate at Tuskegee University, and there is actually a course for a semester you're required to take to have a full understanding of the Tuskegee syphilis study. And, you know, we can, but that's just one of them. We can name quite a few things. There's Henrietta Lacks, amongst other things that we can talk about, or just the, you know, the unfavorable relationships that many of us have had with our healthcare providers just throughout the course of just life. So my perspective of this and the question really isn't limited to just COVID, but really just kind of that medical mistrust overall. That's a bit deeply rooted, especially in most marginalized communities as well. But I do believe that there are a few things that we can learn from a public health perspective, and some of those specific in the HIV arena that will benefit. The one is, I'll start with just acknowledging the mistrust. I think we probably have all had the conversations. I know I have with friends and family today who are really ready for an argument. They're ready for you to come in and say, I'm right, you're wrong, and really no one's right or wrong in that. But it's about creating the space really to hear what someone is saying and to have a little bit of empathy to understand that perspective. I think that's really important with the healthcare team. It's oftentimes what we're met with are the numbers and the statistics and all of those things, and they're hugely important. But it's something about meeting people where they are, again, to not be argumentative, but to meet them where they are and to, go on that journey in terms of educating with them. The second that I would say is just really engaging community groups and organizations that are already a part of the community. So much of what we've seen with COVID is, in the States and a bit here too, wanting to interject new groups or new faces or new people in an already established community versus going in and partnering with some existing infrastructures that are already there and have had success. Two things that come to mind with this for me. The first is a barbershop initiative that was partnered with Black barbershops in the US to get the word out about prostate cancer. The second was similar, again, back to hair in the US with Black women in hair salons to talk about the rate of HIV infections amongst women of color. So those are just two things in terms of ensuring that you're partnering with the right community-based organizations that are already there. From that, it's about creating the material, the language, the vernacular, thinking about how you will deliver that information to the communities that you're starting to reach. And it's from that I think we start to break down a bit the walls of mistrust, but no one can do it alone. And I think there's just so many opportunities to partner with those groups that have demonstrated success in the past, and it should be no different as it relates to COVID as well.
That's a fantastic and very insightful answer. Thank you. I think that has so many parallels also with, queer and trans communities as well, of making sure to meet people where we're at, not trying to interject ourselves or create new systems when there are systems that are working by and for the community. And that also, you touched on kind of mistrust between racialized communities and kind of public healthcare systems. And Safia, I'm wondering if you could comment on that a bit. Yourself working in a community setting, how could healthcare professionals better integrate anti-racist practices and policies into their own HIV treatment and prevention efforts?
That's an amazing question. I think that there are many things that we can do. I think the first thing is to acknowledge that anti-Black and anti-Indigenous racism exists. We know that colonization and institutional racism have been perpetuated through healthcare systems, and they also have cultivated an environment that has been violent for centuries. And so for many BIPOC people, racism perpetuated through healthcare providers can limit access to information and services and can actually introduce barriers to coping and protecting oneself from HIV transmission. So the first piece is just to acknowledge that exists. And so we know that there has been racial bias in pain assessment and treatment recommendations between white and Black patients based on false beliefs about biological differences. We know statistically that there is the prescription of significantly more analgesics compared to white patients. White patients compared to Black patients in an emergency department for bone fractures. We know that there's an screening of Black Canadian women for cervical and breast cancer. And these are very real and tangible realities that exist in terms of access. And so being able to name and validate the lived experiences of discrimination based on race, gender, sexual orientation is oftentimes the first step, not only towards developing the trust that's so integral, but also can introduce a safe space where BIPOC people are valued and validated for the experiences that they carry. And so it's more than just taking an equity, diversity, and inclusion training for healthcare professionals or any element like that. It's not really easy to just take a training and now you're done with it. No, it involves an active commitment. The second thing I think I would say is to kind of just to understand the history and the context surrounding the lack of trust in BIPOC communities. As Dacia had already mentioned, there are legitimate reasons in history where there is a lack of trust for BIPOC people, and where people have placed trust in the hands of healthcare providers, and that trust has been broken. And so, we know Canada's history includes nutrition experiments on Indigenous children. We have situations where people conduct medical experiments and pathologize the behaviors of Black people who were enslaved. And so these are very important and real, tangible reasons as why many people are very reluctant to seek the assistance of service providers. And so we need to actually listen and take the time to really understand the context of that. And then I guess the harm reduction lens, as Dacia was saying, but then also I think that we also need to be able to do the work and research regarding the specific needs and challenges of BIPOC members. And so that includes, we know that ACP people experience HIV vulnerability in relation to a whole host of other pressing issues. That includes unemployment, racism, racial profiling, poverty, language barriers, family breakdown, intergenerational conflict. These are very real things. And so when we talk about the experiences of discrimination on top of all of those things, and based on race and gender and sexual orientation, we know that that can have a negative impact on an individual's well-being. So holistically, through the social determinants of health, I think it's important to kind of consider how those can impact a person's access to and decision-making for HIV prevention methods. So really just to do the work. And then I guess the last thing quick is just to involve BIPOC people in the process of their healthcare very more actively. And we know that there's higher power hierarchies that exist in the healthcare system through the biomedical approach, and that it assumes that the medical professional is always right, and not to question the medical professional. But a lot of the times for communities, especially where trust has been broken, that choice is between life and death, really. So that approach in Western medicine does not work for community. And so communities have to be involved in the consultation process and decision making in regards to that health and health prevention policies that impact them, quite simply. So
I'd like to add a point to those, if that's okay.
Yeah, absolutely.
Obvious points, because they're incredible. And exactly, you're speaking, what a lot of people definitely, have felt personally, especially, it's unfortunate that that's how the healthcare system has been to date. And I'm very optimistic about how it's hopefully going to change with a lot of these issues that have been brought to the forefront. And, a lot of schools have been put under pressure to make changes to their curriculum, to make changes to their staff. There's a lot more conversation around diversity, inclusion, and equity that hopefully will be taking place. But I think as a part of that is we have to be holding physicians accountable to these things as well. We always hold physicians accountable when a procedure goes wrong, or they act out of their medical directives or anything like that. But we're not doing the same with, physicians' behavior, stigmatizing language that they might use, right? These might seem like minor things to a physician who's probably studied, many, many years. And I see that in, even when I've been in the hospital, I hear it sometimes. But it is something that one, false or one bad comment, one stigmatizing comment will deter someone from coming into the healthcare setting again for a very long time. And it's extremely hard to reverse that. So I'm really optimistic, though, that, for example, U of T's medical curriculum has now integrated an LGBTQ and trying to foster more anti-oppressive, decolonized space that encourages this in their medical professionals. And I'm excited that I'm part of something here in Ireland, which is doing a similar thing here in their medical schools here. But it will eventually get there. Unfortunately, I would hope that now, as the younger generation of physicians come forward, they can also stand up to those more senior ones who've been around for a long time, who are not familiar with these things, and attempt to educate them on these pieces. So I think the responsibility eventually falls on us as healthcare professionals to be doing this, not just the patient to stand up and say something.
That's a very good point, and something that I know, especially as well. We have a few CBRC people here, or past CBRC people, and that's been a big thing for the Community-Based Research Center, is pushing more culturally competent care by physicians and healthcare providers to be aware of the kind of intricacies of being queer or trans. Chris, I'm wondering if you had anything that you noticed on the ground as well, or maybe tips for healthcare providers that may be listening that may not know how to be more culturally aware of 2S LGBTQ issues.
Yeah, thanks. I mean, I think that like at a very basic level, you need to understand that, like, you need to, I guess, understand where your own biases come from. And like, you know, you might be a cisgender straight person, and there are things that maybe you're not even aware of that are, that you might assume. And so like, you know, I've had people be like, so like, you know, who's, with my partner would be like, would refer to him as like her because, or like your wife or something like that, when I would give the name for like a power of attorney or like substitute decision maker rather. And so like, I think that there's just these like assumptions. I also see this very often within the context of sexual behavior and within substance use. I just assume that most people won't actually want to tell me everything that they've done. When it's like, how many partners have you had? And I hear like 3 or 4. I'm like, well, we'll probably just like double or triple that, or because they just don't want to like share that information because they've been shamed or judged. And like sometimes it's like it's not even necessarily an explicit thing. It's a bit like someone might have like acted a little surprised or seemed like a bit more shocked. And so then it's like, okay, well, I can't really tell them everything. And so part of it is just that, like, really fostering that trust and building that trust. And it's not like a one and done type thing. Like, yeah, I've asked them the pronouns and all of a sudden I'm like completely like culturally competent to provide care to us LGBTQIA plus people. But like, yeah, I mean, I think that's it's also just important that it's like, you know, we have to do like learning plans as healthcare providers. Maybe that's something that people should think about for the future, and also around like Indigenous and Black cultural competency as well too.
Can I add to that too? I think sometimes we're made to believe it's much bigger, or you need to take a course, or you need to pick it up somewhere. But sometimes it's just the conversations that happen amongst a friend group or at the break room if we're in the office. And it's those little subtle things sometimes. And honestly, that's where I find myself really engaging with people. I love telling people that I work for a company that, you know, our focus is HIV. I love it. And especially in groups where it's not something that's probably talked to, because there's always someone in the room that says, really, I didn't know. I mean, what a great opportunity. And I look for those. And sometimes it's after the bigger meeting that someone's kind of pulled me aside and they want to have a conversation. But, you know, sometimes it's within our circle groups or our family groups and little things that are said. And I think those are the places that we can make just such a sizable impact, because not everyone's paying attention in some of the sessions, but it's just not letting those subtle things slip. You know, even if it's what you used to say or how you used to refer, and it's like, well, you know, we don't say that anymore, and this is why. So it's really just kind of taking advantage of those opportunities that may present in our circle groups, and maybe not always at a work setting or however as well. So.
That's a very good point. And I mean, the one thing that I'm kind of noticing, the one common factor in all these answers, and also Safia's answer earlier when she was talking about community care, is that the base is just like promoting empathy and compassion and understanding, not only towards others, but also towards yourself and towards how you want to approach others. I think that that's just a very good knowledge, like lesson overall, that we can all learn from. Especially in these COVID times when we're socially distanced, maybe. Maybe if I'm going to shift a bit our questioning to bring it back. So what we mentioned to the COVID-19 pandemic, there have been some comparisons in the past between the COVID-19 pandemic and the HIV/AIDS epidemic in the 80s. some comparisons have been more or less problematic, and so my question isn't really to compare both pandemics, but more so, what lessons can we learn from HIV/AIDS and specifically the government's response to it? So as I mentioned earlier, Canada continues to be a leading country in the world in criminalizing people living with HIV, which disproportionately impacts marginalized folks. And we've kind of seen a bit of that criminalization coming up in COVID as well, with kind of more stringent policing measures to address the spread of the virus. And so what are your thoughts on that, and kind of what opportunities do we have to reverse course on that kind of punishing aspect and centered more towards a empathetic, compassionate community care model? Throwing that out to everyone, whoever may be interested in exploring it.
I can start. So I think it's important to also acknowledge that the HIV epidemic continues to this day in Canada, and we're in the 40th year of the HIV epidemic, and we have not managed to stop HIV transmission despite all these advances in medical technology and prevention and testing and et cetera. I think that the real challenge has been stigma and fear and kind of what Dacia was mentioning as well too, around, there's a lot of outdated thoughts around HIV in particular. And I think too, with like the COVID-19 pandemic and how it's playing out here in Canada and in Ontario, that, there's a lot of misinformation. There's a lot of there's also a lot of, like, the government's response to things have not always been the most beneficial for the people who are the most impacted. And so I think what we've seen is that in the HIV epidemic, certain groups, particularly gay, bi, queer men, Indigenous folks, African, Caribbean, and Black folks, people who use injection drugs, are disproportionately impacted by HIV. And within COVID-19, we've also seen people who are racialized, and people of color who are more likely to experience, to contract COVID. I think Peel was the #1 COVID hotspot in all of Canada for the third wave. And that is like a majority South Asian communities that were impacted by that. And so I think that we tend to design these policies that are for everyone, and everyone usually is a proxy for cisgender, white, straight people. And it really then doesn't take into the context of other people who are actually more impacted by it. And so I think that having a bit more nuance in the ways that we approach policymaking within is something that I would encourage all levels of government to do, because really there's no one size fits all. And again, there's this like implicit racism and homophobia and transphobia within some of the policies that are just, sometimes people just don't even see it until it like plays out. So that's my initial thought on it.
And so maybe while folks start of kind of to think about that question as well, I'll jump into another question that Chris's answer made me think about. But by all means, if you want to jump back to this question, please feel free to just jump in. So Chris mentioned, rightfully so, how we are still in the HIV/AIDS epidemic. It has not ended. It's in its 40th year here in Canada and internationally as well. And Canada ascribed to the UN's 90-90-90 goals, which is, whereby 90% of all people living with HIV would know their status, 90% of people diagnosed with HIV would receive sustained antiretroviral therapy, and 90% of all people receiving the treatment would achieve viral suppression. And all of that we hoped to have gotten done by 2020. Obviously, we did not meet those goals. We are here in 2021, for many reasons, but of course the COVID-19 pandemic did not help. So how can we kind of compare our efforts? How do we compare our efforts to the goals, and where do we go from here to achieve them?
Yeah, I'm happy to start there. I think for a lot of the reasons that we've talked about already, just in terms of the impact of the epidemic of COVID, just overall on healthcare, I hope that we get a little bit back on track. But, everything we've said in terms of, what's happening from a testing perspective, and there's certainly some folks that can speak to it in more specificity than I. And then just from the suppression perspective as it relates to, how is it really going in terms of how are we prioritizing HIV medication and adherence to HIV medication with everything else that's going on that a lot of other things folks are balancing throughout this time as well. And so, my hope is that as we, get to a place that we're able to have a bit more live interactions with families, with friends, with someone who, when you say, how are you, you're able to look at them eye to eye and not really eye to screen to say, how are you? I think it's when those things start to happen that we start to move the needle a bit. But I think to some of the points that we made earlier, as it relates to some of the mental health hurdles that have really come to play, in light of COVID, it really will be addressing some of those things first. So my hope is that we take the moment to really pause, to really think about the person, the individual as a whole, and how some of the downstream impact of COVID may have affected that before we jump back into just trying to meet that just for the sake of just trying to meet it. So, so I'm optimistic, but I certainly realize there's lots to be done to get us back there as well.
And that actually makes me think of, sorry, go Chris.
I was just going to plug, if we had a national pharmacare program, that would really help. But anyway, that's an entire different discussion. But I think that would be, especially as we're in the midst of an election, I think it's also important for us to think about, some people can't access medications, and it's like hoops to get into things, and new medications that are available, like Descovy for PrEP is not on the Ontario. You can't actually access it through the Ontario drug benefits. Cabotegravir, you can't access through Ontario drug benefits either, and so it's we have all these new technologies. Could help with that, but we're not able to get people can't access them in the way that they should be able to.
That is a very good point. Actually, I was actually just about to ask you, Amir, your studies you've been studying the impact of COVID-19 on PrEP uptake and on STBBIs in the Toronto area. What can you tell us about that?
Yeah, I'm going to make a point to Chris's point, and then I'll move on. I'm also a member of the Canadian Doctors for Medicare, which is an association of physicians that work to make sure our public health system stays public, and also is advocating for a universal pharmacare as well. And this is going to be an ongoing fight. And again, as Chris was saying, it is so important to be pushing this forward, because Descovy, as an example, is such a good option that should be made available to people who may have certain kidney conditions, but is unfortunately not listed, at least within the Ontario drug registry. And so as a result, we have to be pushing for that. And I urge anyone who is out there to push it with their own members as well, or their candidates, and to get them to approve this. And in regards to the study, so this is a study that is looking more at overall, what we wanted to do is to kind of compare the 6 months before the pandemic, the 6 months of the first wave, and the 6 months of the second wave. And now there's obviously the third wave that, we are now looking into slowly. It isn't as big as the other ones, but it is still a third wave. So we have not fully finished looking at all of those pieces yet. But But some of the impressions that we have as of now is that there's definitely a significant discontinuation of PrEP from throughout the pandemic that happened. Parts of that, it would probably have to do with not having access to healthcare in the same sense. Before that, everybody would have 3 months. You would come in to see your doctor or the clinic that you were in to see the nurse, and you would get your swabs done, your blood work done, everything as a one-stop shop. And that has always been one of the key things around PrEP uptake, has been making sure it's a one-stop shop. Oftentimes the pharmacy might be attached to the clinic as well. So this is exactly, you get everything and you leave. Fortunately, something like swabs cannot be done at laboratories. So you have to do that at your doctor's, right? And so that has limited it a little bit, requiring you to do multiple visits, talk to your doctor, then get your blood work somewhere else, then go do your swab somewhere else, then get your meds from somewhere else, right? And so what we're seeing is there potentially, if I don't have the exact numbers, but impacts on it. And we've seen that in other countries as well. So it's not just Canada, but we see that in Australia, we see that in the States, in San Francisco, for example. And there's also been something that other studies have found is an increase in STD-BBIs, including HIV, including other STIs. The thing around HIV is many people stopped taking PrEP during the pandemic, thinking that, I would not be, interacting with people, socially distancing. But as we have seen, that has necessarily not been the case. And the apps were still as active as they have been, if not more, because people were not now going to a bar to see friends, and they weren't doing so. They were at home a lot more. And that may be two parts of that. We still have to examine the data a little bit more detail to see if it was more like, because we didn't have testing in the same way for those 6, to a year properly in the same sense, maybe we have some, we're picking ones that naturally occurred, or was it as a result of the pandemic or services? So we're really eager to see how that turns out, and hopefully be presenting those results at CAR in the coming year.
Well, I am also very eager to hear how those results turn out. Thank you for keeping us updated so far, Amir. And we're getting close towards the end of our panel, so I just want to take a quick moment before we end to maybe finish on a high note and ask you all very quickly, what is something in your field of work or in your own community that you are excited or hopeful about in regards to HIV prevention and care? And I'll open the floor in no particular order to whoever has a thought to share. What are you excited about or looking forward to?
I can go. I think what I personally think that I'm seeing more and more is just having more of a diverse array of professionals that are from BIPOC communities. I think that having an array and different sets of lived experiences and people within lived experiences becoming professionals has been really integral to connecting people to supports that where they have people that look like them and understand the challenges that they go through. I think I've been very grateful and excited to see the insurgence of that and seeing how that's also implemented in the types of work that is being done that addresses the needs of communities that are marginalized more appropriately than I've seen in the past. So that's one thing that I'm like over the moon about.
So I'm happy to go. Sorry, Amir, do you want to go? Oh.
Go on.
Okay. I was just going to say, I think for me and the work I do, what I'm excited about, continue to be excited about is where we are right now. It really is, pharma partnering with community, and to be able to sit here with, just my esteemed colleagues today to have this discussion is really what keeps me here and what will keep me here in the future as well, as it relates to just the excitement that'll come. So thank you for creating this space for us to join today as well. So that's for me. Amir?
Yeah, I think what has been very interesting throughout this pandemic, and that's something that is brought into our attention is the importance of allied healthcare providers, not just in the sense of, we have the physicians and we have the nurses, but obviously this pandemic showed us how things can change really quickly and how we need everybody else as well, and how vital it is for those people to be involved in patients' care. And so I'm really excited to see how that will go. That will more pharmacists, seeing now that, expanded testing and, taking testing and vaccinations to pharmacists and many other healthcare professionals. So I'm hoping that we can do the same and leverage our amazing social workers and many mental health workers and work closely with us as physicians to hopefully work towards the betterment of the patient.
I'm going to try to sneak in two things, if that's okay. So one, I think that the pandemic has shown that if we have the will to, we can pivot very quickly to do a lot of different things. And I think that the unfortunate challenge is that HIV tends to impact people who have less political clout or power. And so there just we haven't seen that. So I think that, it's shown that as a society, we can actually come together to ramp up testing, to get vaccines into people's arms and things like that. And so I'd like to see some of the learning applied to HIV prevention and HIV care, including the expansion of virtual care as well too, because I think that while that's not for everyone, it is a great option for some people. I'll also just say that I'm super excited about the recent Moderna HIV vaccine trial based on the mRNA, the technology, which just launched a few days ago. And so I think that if this is a opportunity, there's lots of HIV vaccine trials, but, this is a novel technology. So I'm really excited to see the results of that and hope that, that we might have a HIV vaccine at some point in the future.
Yes, that's also very exciting news that I'm eagerly following to see where it leads. And so that seems to be all the time that we have for today. Apologies to cut it short, but I know that we could have had many, many more hours of great conversation, and I am so grateful to all of you who have joined us and brought all of your knowledge and expertise to tonight's panel. So thank you sincerely again to all of our panelists tonight who have joined us. Thank you to our audience who are tuning in to us either on Facebook or on Capital Pride's website. And if you haven't yet, I invite you to check out the rest of the planning that we have for Capital Pride's week of events on the website capitalpride.ca. And if you go to other events, then I hope you a great rest of Capital Pride and a great rest of the summer. So thank you all sincerely, and look forward to continuing this conversation offline.